without further ado, I'm introducing Dr. Kristen Campbell, who will present today on the role of exercise in survivorship. Kristen's larger body of work includes exercise in cancer prevention, rehabilitation, as well as survivorship. And she's a licensed physical therapist and associate professor at UBC's Department of Physical Therapy. You have the short bio notes as in the announcement. I want to highlight that she is a co-lead, the first author in the 2019 exercise guidelines for cancer survivors from the American College of Sports Medicine. And as I look at the document, we are delighted to have Kristen here today with the knowledge and evidence she brings, given the extremely large body of work in developing the guidelines. So I'm passing you the mic, so to speak, Kristen, and I will pick up at the end when you're ready to take questions and comments.
Great, thanks so much, Armine, and really thanks for the opportunity to speak to everyone today through this webinar series. It was planned a long time ago, and we decided to proceed regardless of what was going on. So thanks everyone for joining and taking the time today. What I'm going to be speaking about is the new international exercise guidelines for cancer survivors, mostly around the development process and sort of what they turned into, and then what next steps we can take from there. Oh, if I can advance the slides, we'll be in business. Let's see. Oh, there we go. Okay. So today, really describing the key factors that support development of updated roundtable and guidelines and why we did this work. Outline the main findings of the 3 resulting papers. Kind of summarize the literature, the limitations of these guidelines, and the need for future research. And then just kind of highlighting how we sort of tried to take this research into practice in BC and just with some examples. So this is what we remember of the 2010 physical activity guidelines for cancer survivors. They were the first of their kind when they were published in 2010. And the main recommendations here were to avoid inactivity, first and foremost, to return to daily activities as soon as possible after surgery, continue normal activities and exercise as much as possible during and after non-surgical treatments. And then overall, the recommendations for physical activity were the same as age-appropriate guidelines for Americans, because it was from the American College of Sports Medicine. And at that time, that was at least 150 minutes per week of moderate to vigorous physical activity, or 75 minutes of vigorous activity, 2 days a week of strength training and daily stretching. So there was a lot of discussion in the room at the time for developing the 2010 guidelines around what should the recommendations for physical activity be. And at the end of the day, there was nothing to preclude just making it the same as for Americans, because we didn't have a lot of information to tell us it should be more or less. And so that's what we sort of defaulted to. There was some discussion at the time that potentially that was not the right target, that we should have maybe looked at what the recommendations were for older adults, or had a bit more, something more specific for cancer patients. But at that point, really, there wasn't enough evidence to say what it should be other than this recommendation. So fast forward to 2018, the second roundtable was undertaken. This time it was more international, more multidisciplinary, and also took on cancer prevention as well as cancer control as part of the mandate. You can see here, these are all the groups that were associated or partners in this work. The American ones are on the far side there. Canada had CCSRC was the Canadian partner, and then you can see some more international organizations there. This was the photograph of everyone involved. You maybe see friends or yours or people that you recognize. The reason the person in the front is dressed like a beefeater is that the hotel we held the meeting at had a British theme, and so this was the door person, and we saw him a lot, and he wasn't part of the discussions, but he certainly was part of the meeting. And this was held in March of 2018 in San Francisco. So the challenge we had at that meeting to try and figure out what we will do to update the guidelines was, this was the primary one. There's a lot more literature. And so that was a great thing, but it also was the challenge. And this was just one slide put together by Joachim Wiskerman, who was part of that group, that there'd sort of been a 144% increase in the number of publications from the 2010 roundtable, which was held in 2009, to 2018. And so you can see the number of randomized controlled trials that were available. So we really had to find a way to deal with that new evidence in the most effective way. Also, as I mentioned, we are expanding to include prevention and cancer outcomes. And what we really wanted to acknowledge was that there was more research on other cancer sites. So the early 2010 guidelines were primarily reporting on early stage breast cancer and a little bit of prostate cancer. So really trying to figure out what else we could say about other sites. Look at other treatment side effects than what had been looked at the 2010 guidelines, and really look at clinical outcomes, things like recurrence, survival, chemotherapy completion rate, decreasing toxicities, those type of things. So what I'm going to go through is just briefly talk about each paper. I was most involved in paper 2, so I'll spend more time there. Paper 1 is really looking at cancer prevention and control. So what was the observational research that could link exercise and physical activity to decreasing risk of cancer, decrease occurrence of cancer, and improve all-cause mortality and cancer-related mortality. It also started to take on sedentary behavior as well, so the new sort of player in the physical activity realm. The lead authors on this were Alpa Patel, and the senior author was Chuck Matthews. So this is primarily what was generated from that particular paper. And so you can see here that exercise for cancer prevention and treatment, that for adults, exercise is important for cancer prevention, specifically for 7 common types of cancer, and you can see those listed here. What they estimated, there was a 12 to 28% reduction in risk of these types of cancer in those that were more active compared to least active. And the one thing that they did mention that was sort of a different piece was that physical activity may actually increase the risk of melanoma. They did see a 27% increase in risk. However, they did note that really was tied to sun exposure, and so just really reiterated the need for sun safety in fact that, you know, if you're outside doing activity, it's good for you, but make sure that sun safety is part of your approach. In terms of what they could say about recurrence and survival, what they just could look at is that post-diagnosis physical activity. So after an individual has been diagnosed with cancer, they found a consistent inverse association for breast, colorectal, and prostate cancer for cancer-specific mortality and all-cause mortality. And you can see the sort of percent reductions there. So it only was for those 3 cancers. The important piece too, that at the end of the day, all of these 3 papers with the guidelines tried to focus on the fit prescription, frequency, intensity, type, and time, to really try and narrow down, well, what is the exact dose or prescription that's most effective? And so what they saw in this paper looking at the cancer-specific and all-cause mortality is that the exact dose of physical activity needed to reduce cancer-specific and all-cause mortality is not yet known. There are too few studies that have been conducted that have detailed data on the risk associations and specific doses of activity. So right now, a lot of the observational research is self-report activity and really doesn't get into the nuances of it has to be frequency or there's an element of intensity that's key. At this stage, there's some emerging research, but there wasn't a significant body. There, I just coughed into my sleeve. A significant body of research that could really pin down this exact dosage. So for paper 2 then, our goal here was really to sort of recreate the 2010 guidelines, talking about what are the physical activity guidelines that should be used for cancer patients. I co-led this with Carrie Winter-Stone from the Oregon Health Sciences University in Portland, and the senior author here was Katie Schmitz. I also would like to acknowledge the wonderful team of people who are here. This group took on a massive undertaking of looking at all the literature, looking at exercise and cancer outcomes like fatigue and quality of life and things like that. So this is a very heavy lift for and everyone in this group really contributed. So when we thought about trying to update the 2010 guidelines, there was a lot of discussion, like how do we, now that we have more evidence, really make these more usable? People have asked for something that's a bit more specific for cancer patients. How do we best do that? And so we sort of thought about the approach. Would we do the guidelines kind of focused around different symptoms, adverse events, and side effects? So is that how we would sort of organize things? Would we organize it by type of cancer? So breast cancer, these are the recommendations. Colon cancer, these are the recommendations. The other potential we had was maybe by treatment type. So after surgery, it's this, chemotherapy that, radiation the other, and immunotherapy. And then time frame also came up. Should it be sort of prehab, during treatments, or adjuvant or neoadjuvant therapies, rehabilitation, survivorship? So should we make different guidelines for that? So this is the question that we had. And so we spent time in that roundtable in-person meeting kind of discussing that. So then in preparation for doing the guidelines, we then had a survey that went out to people around the world who were involved in cancer and exercise. People on this call may have answered this. And so just asked about what sort of programming you already were running, and then asked you this question. Cancer exercise guidelines could be organized by tumor site, outcome, treatment type, or time frame. We want to know how you would rank them, and rank the category 1 to 4, with 4 being the most important. So I just want to ask people, just think to yourself, and I'll go back to the slide before, in the perfect world, what would have your response would it have been? Would it have been an outcome, cancer diagnosis, treatment, or time frame? And there we are. So this is the results from that survey. We had 175 respondents, and you can see here 1 was least priority, 4 was highest priority. And here is what the scores were. So pretty similar across all the different types. But what we did see is that for cancer outcomes, that seemed to have the sort of highest mean score, for lack of a better term. And that was how we felt we could easily sort of handle the data. The other one that was really popular, I think is relevant here, is by tumor site. And that was a comment that we heard a lot, because typically when we're interacting with healthcare professionals, oncologists, for example, they are used to thinking about things in tumor sites. Like breast cancer has their own tumor group, and colon cancer has their own tumor group as part of the GI group, and those type of things. So that was a discussion. We tried to parse it out. There really wasn't a lot of specificity we could give by tumor site. It was more so around the different outcomes. So we did use outcomes as our main framework. So these are the a priori decisions that were made when we started to try and undertake this monumental look at the literature. So in the in-person roundtable, we developed a whole list of potential symptoms and side effects affected by cancer, that came from cancer, that could potentially be affected by exercise. This was all brainstormed here, and you can probably see your favorite outcome on this list. Then there was a real discussion that ideally wanted to have a bit more precision around the prescription. So using the FIT principle: frequency, intensity, type, and time. What can we give, what parameters can we give people that are a bit more specific, using this very standardized approach to exercise prescription? Those in the exercise world use the FIT prescription every day. And for others that maybe are coming from a different perspective, this is sort of our fundamental principle. Everything has to be the FIT principle when prescribing exercise. So in terms of then kind of tackling where we wanted to start, in the roundtable meeting, it was sort of identified what were the main things that people felt were the top 20 list. And so we went from there and started operationalizing a literature response review around those top outcomes. So what we did, I'll go back here. What we then did is we did literature searches. We worked with the healthcare librarian at Oregon Health Sciences University, OHSU, to do a search on all the systematic reviews and meta-analyses that had looked at these particular outcomes. If there were no recent and systematic reviews and meta-analyses, then we did pull randomized control trials. Sexual function was a good example of that. So what we wanted to do is that we realized that a lot of people had already done a systematic review of the literature, so we leveraged off those systematic reviews and meta-analyses. We were given sort of 9 months to do this and with no budget, and so that was the most sort of feasible and approachable way to do this. So then what we determined using a decision tree to determine if we could provide a FIT prescription for a particular side effect or symptom. We really had to thank Anna May, who is part of our team for this. She suggested this framework that had been used for the Dutch physical activity guidelines in 2017, and we adapted it sort of for our purposes. So what we then said is we only looked at randomized control trials that had then been in systematic reviews and meta-analyses potentially. If there were less than 5 studies, we deemed this insufficient evidence and no fit prescription was developed. If there were more than 5, greater than or equal to 5 randomized control trials, and there was at least 150 people total in all of the trials, if the effect was close to 0, so really you couldn't say if it was beneficial, yes or no, then the effect is unlikely, we didn't do a fit prescription. If the effect was not close to 0, so there actually seemed to be a change in the outcome based on being part of an exercise intervention or physical activity intervention, and there was no heterogeneity in the direction. So everything was like it all improved with being randomized to an exercise intervention. We deemed this strong level of evidence and a fit prescription was generated. If there was some heterogeneity in the direction, so majority of studies said yes, but there were some that said no, then we kind of moved it into this emerging potential benefit in high quality or newer randomized control trials. I'll talk about sleep, and that's really what sort of ended up here. And so this was sort of a moderate evidence, and we had sort of a fit prescription that can be generated, but there were some caveats. If there's a lot of heterogeneity, it was just all over the show, we said the effect was unlikely or we just couldn't judge it at this point, and no fit prescription was generated. So from there, we did all the literature searches. Everyone in teams of 2 was assigned different outcomes. They had to look at all the systematic reviews and meta-analyses. They had to determine what their recommendation was based on this flow diagram. And then we had a series of calls where a certain number of groups had to present their analysis of the situation, have it vetted by the entire group. And then we all as a group had to agree that, yes, we felt that this outcome fit into this category, and we worked from there. So this is what we came up with. So overall, to avoid inactivity, that still held clear that more movement was better than none. And so we held that same from the 2010 guidelines. The next was really to improve general health, aim to achieve the current physical activity guidelines for health, 150 minutes per week of aerobic exercise or 2 days a week of strength training. So at the far end of the spectrum, there's nothing to suggest that improving general health, we still were aiming for those physical activity guidelines for general health for all adults. What was different in the middle then is what we then found is from our review of the literature, there was, if you wanted to address a particular symptom related to cancer treatment, such as cancer-related fatigue, there was a dose of exercise that was slightly below the guidelines for general health that started to show a signal for improving that outcome. So for cancer-related fatigue, 3 days a week of at least 30 minutes per session of a moderate intensity activity showed a signal for an improvement in cancer-related fatigue. You can see here we also were able to generate a fit prescription for health-related quality of life, physical function, anxiety, depressive symptoms, and lymphedema. Here is what we found for aerobic exercise. So this is aerobic only. You can see here that for cancer-related fatigue, at least 30 minutes, health-related quality of life, sort of up to 60 minutes, and 2 to 3 days per week was generally the amount. With lymphedema, we didn't find any evidence that aerobic exercise, for example, improved symptoms of lymphedema, for example. So then we also added in here resistance only. So in this case, what we did see is for cancer-related fatigue, for example, 2 days a week of 2 sets to 12 to 15 reps of the major muscle groups at moderate intensity did start to show an improvement in cancer-related fatigue. And you can see it's pretty similar here. Here we can see here that for health-related quality of life, a larger rep range seemed to be beneficial, so you could pick within that. And for physical function, for example, 2 to 3 days per week seemed to be beneficial. What we really wanted to say about lymphedema, and I'm sorry that this other piece is sort of popped in the middle here, this was the main recommendation for lymphedema, that 2 to 3 days per week of progressive, supervised program for major muscle groups does not exacerbate lymphedema. So for lymphedema, it really was more like a safety piece that we could recommend a fit prescription as opposed to being able to treat lymphedema, for example. There isn't a lot of room on the slide, so I think I kind of, so then we also looked at the combination of aerobic and resistance training together. And so you can see here that for cancer-related fatigue, for example, it's 3 days a week for 30 minutes of moderate intensity activity, plus adding this aerobic exercise. What we have generated then is that any one of these approaches can work. So if someone is interested in only aerobic activity, they just want to walk, they don't want to do anything with weights, if you go back to this table again, which you can find at acsm.org, they can, 3 days a week of aerobic exercise will do the trick. If someone really only likes resistance training, that's all they want to do, this amount of resistance training should show a benefit. And then if someone is game to do a bit of both, sorry, this is really touchy, it only lets me do it with a mouse. If someone's interested in doing a combination of both, then you can do a bit of both and see a benefit as well. And so really the idea was these doses seem to show a benefit in terms of this type of activity. So it's like, pick your idea and what works for you, what equipment do you have, what are you interested in, and kind of go from there. Obviously, aerobic and resistance training is probably the ideal if someone's interested in doing that, because that will sort of get them down the road potentially to meeting the current physical activity guidelines for health as they start getting stronger and more familiar with activity. So then in terms of the moderate evidence, so this was the category where we thought there was some kind of emerging signal from more relevant recent RCTs. We did feel that there was some ability to do a fit prescription for bone health and sleep. And so I'll start with sleep first. And this was mostly focusing on recent RCTs that for sleep, 3 to 4 times per week of 30 to 40 minutes per session of moderate intensity aerobic activity seem to improve different sleep outcomes in individuals who were undergoing a cancer treatment. For bone health, there was a signal potentially with resistance training only that 2 to 3 days a week of moderate to vigorous resistance training plus high impact training sufficient to generate ground reaction forces of 3 to 4 times body weight for at least 12 months may have an improvement in bone health, but more research was needed to really go to, because there was only sort of moderate evidence for this. So this is what we tried to generate as an infographic that could be maybe a little bit easier to manage. I think this chart that we developed was really for exercise professionals. If they wanted a cheat sheet of sort of what they need, where they need to start with, that was really the audience that infographic was developed for. And it is available free in the ACSM resource library. Then we tried to develop an infographic that was maybe more user-friendly. So a lot of you potentially received this and gave feedback on this as well. So thank you for those who did that. You can see it's a similar approach to kind of using the same kind of idea here. Here's all of our prescriptions where we could had moderate or strong evidence, and we could develop a fit prescription. So research shows that exercise helps with the following cancer-related. I can't see what it says on my screen. And then to manage these symptoms, you can pick an exercise plan and get started. Aerobic exercise or resistance exercise or the combination. And this should help with the certain symptoms down here. There's a lot of questions. So this lines up with cancer-related fatigue, health-related quality of life. Our purple is physical function, red is anxiety, orange depression, and yellow is sleep. What you'll see is there is some questionable, why isn't aerobic plus resistance not just everything? Because you can see that sort of we cover both with it. But really, was there evidence that this kind of prescription did help these outcomes is what that meant. So you see for resistance training, it has bone health, but you don't have that for aerobic and resistance because this was the prescription that started to show benefit for the other outcomes. It has nothing about high load trainings for bone health, for example. We did a lot of workshopping on this. It's not perfect, but that was our attempt. And so in terms of this, it's being workshopped a little bit more with cancer patients themselves to get the wording right, and then it will be available as well. So as soon as that has a home, I will certainly let everyone know by Twitter. So another piece that was key for this particular paper was exercise clearance and triage. This is an ongoing discussion in the literature. How do we best ensure safety and have best protocols in place while not putting barriers around having medical clearance and treadmill tests and things like that in the way of getting people activated? So this was a huge discussion with the group, and so this is the approach that we took. So the guidelines from ACSM are focused on, obviously, then using the pre-participation guidelines that are already developed for ACSM for people with general health conditions, or for anyone really. And so we kind of leveraged off what ACSM does about pre-participation guidelines to start with, and then overlaid cancer. So, for those that work in the field, basically the new participation guidelines, which came out in 2015, really focused on kind of what do people already do. So if they're not already participating in regular exercise, then you start screening them for cardiovascular and metabolic and cardiovascular, metabolic, and renal disease and symptoms. And so you can see here it's sort of a drop down. If they have none of these health histories, they have no symptoms, medical clearance is not necessary. Start with light to moderate exercise and then generally progress. And so then you sort of move into a group that might be asymptomatic or have a known disease status, and that's where medical clearance might be recommended. What the key piece is here is that medical clearance is not defined in great detail. It's sort of using the judgment of the healthcare team or the setting that you're working in to decide what medical clearance is. So it could be anything from just a conversation with the physician, a sign off by the physician, to a treadmill test or anything in between, which was a big change for ACSM. And for those that have lived through this, they sort of know what those differences are, and I won't belabor them. The key difficulty, though, is that it doesn't explicitly address the risks related to the adverse effects of cancer treatment. Cancer does not come into any of this approach. And it screens for evidence of underlying, so basically we suggest you screen for evidence of underlying cardiovascular disease as per the guidelines, was the main piece that we sort of took from that. And then we sort of overlaid the cancer piece. And so here we leveraged a lot on the NCCN approach that had been generated from that particular group. And so this is from the Survivorship Guidelines version 2 in 2018. And so when you think about, after you've done your screening from the ACSM credentials, then you think, okay, if someone has no comorbidities, then we suggested that for evaluation, prescription, and program recommendations, that no further pre-exercise medical evaluation, and you can see the star medical evaluation as per NCCN guidelines for specific symptoms and side effects, and to follow the general exercise recommendations. So just proceed. If people had peripheral neuropathy, arthritis or musculoskeletal issues, poor bone health, or lymphedema, then there was a recommendation of a pre-exercise medical evaluation and modify the general exercise prescriptions based on the assessment, and consider referral to a trained professional. And so trained professional is defined as rehabilitation specialists, so PTs, OTs, and physiatrists, and certified exercise physiologists. And so we used sort of the main credentials that were available in Canada, the US, and Australia as the definition. So in Canada, that's the Canadian Society for Exercise Physiology, certified exercise physiologist, and that's kind of the credential. And then for those that had lung or abdominal surgery, ostomies, cardiopulmonary disease, ataxia, extreme fatigue, severe nutritional deficits, worsening or changing physical condition, or bone metastases, then a pre-exercise evaluation and clearance by a physician prior to exercise is required, and referral to an exercise trained professional is highly recommended. So it's not considered now, it's like, please refer them to someone that has experience working with this population. I'm happy to answer any questions on that after the webinar. Also, too, for the 2010 guidelines, there was some additional text around other special considerations. So beyond triage and screening, once we start giving prescriptions, we've screened, we've decided we're going to work with this person, there was a bit of guidance specifically around, how do we adapt our exercise prescriptions for things like bone loss and metastases, older adults, if there's an ostomy. And some of that was covered in the original 2010 versions. The key pieces that were added, I think, so we updated all of this, but then the pieces that were added for the 2018 roundtable were symptom clusters and sun safety. So symptom clusters was the acknowledgement that a lot of these things, if you're picking an exercise prescription, for example, cancer-related fatigue may track with feelings of anxiety, as well as reductions in physical function. So all these things play together, and so you need to sort of pick, what's the goal of the client, what makes the most sense for where to start people with, and how do we sort of address all the elements that are going on in the best way. And sun safety was, just a good practice that needed to be included that hadn't been in the 2010 guidelines. So some limitations to the 2019 guidelines. As much as we try and get away from it, there is more research in other types of cancer. The majority of research is still from individuals with early stage breast cancer and prostate cancer. And so even as we're looking at systematic reviews and meta-analyses, and there are more in other cancer sites, we're always going to be stuck with the fact that there's so much more in breast cancer and prostate cancer. And that's, I don't think it's going away anytime soon, so we just have to acknowledge that. Specific to advanced cancer, there is very little research in order to inform a fit prescription or approach for those with advanced cancer. So more work is being undertaken subsequent to this to try and work on that particular question. In terms of developing a fit prescription and what's the most effective exercise dose for a particular outcome, there are very limited head-to-head comparison trials with different types of exercise or different doses. So it is hard at this point to still really tease out what's the most effective dose, because we don't know, is resistance training better than aerobic training? Is 60 minutes better than 30? There are some trials that have looked at that, but they're a handful. And so much more research is needed to really refine that prescription to answer that question. The question of supervised versus home-based also came up in looking at head-to-head comparisons. Consistently, I haven't highlighted it here today, but it is in the 2019 guidelines. Greater benefits are consistently seen with supervised activity versus more home-based or distance-based interventions. And that is consistently shown, and I think it's something in the field we're gonna have to grapple with, notwithstanding the current situations, but how do we, as a field, grow to be able to provide the best prescriptions with good supervision and encouragement and ability to really challenge people, knowing that potentially distance-based methods are coming. And I think there's really limited research in other modes of exercise. So there was a lot of interest in yoga and qigong and things like that, but there wasn't really much we could look at for a fit prescription or to really be able to give a dose around some of those other interventions. The yoga trials all have very different types of yoga, and the reporting of what exactly is happening in the trials, which it also happens in exercise trials, it made it a challenge. So paper 3 was the final paper that came from this suite of papers. And the goal with this one, the audience for this was really the healthcare system, medical and radiation oncologists, our surgical colleagues. How do we actually take what's known from the exercise world and move this into oncology practice? And so this is engaging to help patients move through cancer. The lead author of this was Katie Schmitz. The senior author of this was Chuck Matthews. And this was published in CA a Cancer Journal for Clinicians at the same time. So all these papers basically came out on the same date in October. So the goal with this paper is to kind of run through, well, why is it not happening already and how do we change that? So here is, kind of the background. Why don't clinicians talk to patients about exercise? This is probably not news for anyone on this call here. A lack of awareness about the potential benefits of exercise for cancer populations. Uncertainty regarding safety or suitability of exercise for a particular patient. Lack of awareness regarding available programs to help facilitate exercise for cancer populations. And belief that referrals to an exercise program is not within the scope of practice of oncology clinicians. They felt like they had too much to do already. They couldn't take that piece on. So what this group who were tasked with sort of taking what we found in the first two papers and operationalizing it was suggesting to use an approach that's used in exercise medicine of assess, advise, and refer. So using kind of the same approach that was used for distress screening in a variety of sites here in Canada, certainly, and I'm sure it's used around the world as well. Having people just come in, use the distress thermometer. Once you hit a certain threshold in your response, it automatically triggers a triage to, some programming or follow-up. And that was the idea here too. What can we do around asking about physical activity that's easy, that would alert the oncologist to at least advise and refer people to programming that's available. So this is kind of the graphic of how they tried to operationalize that. So with ASSESS, what they were asking is that whether it's the medical oncologist, the nurse practitioners, the clerk, whoever was sort of asking these questions, how many days during the past week have you performed physical activity where your heart beats faster and your breathing is harder than normal for 30 minutes or more? Question 2, how many days per week have you performed physical activity to increase muscle strength, such as lifting weights? So the idea being if, and then would this patient be safe exercising without medical supervision, things like walking, hiking, cycling, weightlifting? So the answer to number 3 is yes. So then you would advise people about the fact that, exercise is good, that you want to try and meet this minimal amount of aerobic activity and resistance training, and refer them to a best available community program. The piece here then is if you're not sure if the person would be appropriate, or you don't have the capacity to evaluate if they'd be safe, then the idea would be to advise the patient to follow up with the outpatient rehabilitation healthcare professionals for further evaluation, and refer individuals to outpatient rehab or other programming that you felt met that need. So the big question then is, well, refer where to what? And this is going to vary very much based on the setting you're at and what is actually available in the communities. In a perfect world, that referral goes straight to your outpatient physiotherapy and OT and speech and language group, who then do an assessment and triage people out to the wonderful exercise rehabilitation and exercise programming that's available, like cardiac rehab or pulmonary rehab at your center. That's great. Not the case in most places. And so the effort then with this group then was to have at least a registry that could connect people in the community and healthcare teams with what's available in their own community. This is called Moving Through Cancer. It's an ongoing development. So if you have programming that you would like to be listed there, please contact them at this website here. It's exercisesmedicine.org, and it's Moving Through Cancer beyond there. And so this is a work in progress. It's gaining more and more entries every day, and there is a vetting process, so some basically minimum standards that people have to meet in order for their program to be listed there. Also key to this paper, they talked a little bit about the types of programming that would be available, just to try and kind of demystify for the medical oncology world or the oncology world what these different programming is. So those in the exercise world are very clear on sort of what a healthcare provided supervised program would look like. So that's cancer rehabilitation or therapeutic exercise that is inpatient or outpatient. It's usually based in a medical facility. Healthcare providers are the clinical exercise physiologists, the PTs, the very sort of highly skilled, very more clinical model type exercise. And then a community exercise program could be supervised or self-directed. And again, that might be a setting where it is in the community or a fitness center. This might be working with exercise physiologists, but it could be fitness professionals who have sort of a lower credentialing that maybe work with a variety of populations, peer coaches, nurses, or it could be self-directed at home. We'll talk a little bit about that. What does that look like? And sort of making it clear sort of what level of supervision was available and kind of what type of person might fit best between these settings. With the appreciation too, there was the idea that this could be, there's a lot of communication. Potentially, the oncologist could refer someone to a healthcare provider. They go through this wonderful clinical rehab type program, and then they can graduate out to the community. And so there's some passing on of information. Or there's people here who are doing really well in a community program, but at some point they have a new symptom or progression in disease. Could they then shift back upstream to the healthcare provider in the more supervised program? That was the idea. So what they noted, of course, is this is a framework and this is a suggestion, but there are many barriers to overcome. Biggest one being the program availability varies very much by geography. Some programs are very established and have very set referral patterns. Others are just emerging. Some have really, if you were an oncologist working in some setting, there's nothing to refer to. So there's a lot of challenges there. As I mentioned, the supervised programs do seem to net better outcomes, but of course that is a challenge with, Canada being a place that has a lot of rural and remote, and our population lives far and wide. Is supervised programming really feasible? And how do we potentially use technology to get that same exercise stimulus to get similar results with other settings? And obviously, fundamentally, behavior change is needed at all the levels we talked about here. We have to get the patient potentially to change behavior practices. We're asking the physicians and nurses and everyone working in the oncology treatment process to change their behavior a little bit, to start doing this ask, advise, refer. And then, family, community levels, being supportive of their loved one, being active during treatment. There's probably some education that needs to happen there. And into the community, what programming are we sending people to? How do we upskill potentially our fitness professionals to handle this group? So they really ended sort of with this call to action. And so you can pick out who you are on this list potentially and see what you're supposed to be doing to really help this exercise as medicine approach in oncology care. So the example here is the oncology care team and primary care providers to do the assess, advise, refer. For people like rehabilitation and exercise healthcare providers, maybe do some additional training to meet the unique needs of cancer patients and understand that. Clinical educators, so at UBC, we teach the physical therapists, so what can we do to expand the educational training we give to our healthcare providers so they can work in the oncology field, all those different pieces. So really a call to action of how we can do this type of work. So overall, to summarize the 3 guidelines papers that came out of this 2019 effort, the guidelines are an evolution. They're constantly evolving. 10 years from now, they'll be the next generation. So paper 1 really confirmed the role of exercise in cancer prevention and the emerging evidence on survivorship. So when they were talking about exercise and certain amounts decreasing risk of cancer-related recurrence and all-cause mortality, that was kind of a new piece that they were adding. Paper 2 provides clinicians with greater evidence for specific exercise prescriptions to address key and common side effects or symptoms of cancer treatment. And paper 3 was really this call to action to the oncology team to get engaged and at least bare minimum assess, advise, refer. So just as a follow-up, I did mention in paper 2, we were challenged by advanced cancer. There wasn't a lot of research that we could look at there. So we did then follow up with an international multidisciplinary working group on guidelines for individuals with advanced cancer and bone metastases. This is led by a team of Jen Goulard, who is a radiation oncologist at BC Cancer Victoria, myself, Sarah Weller, a clinical exercise physiologist who's very experienced in exercise and cancer, and Prue Cormie, who is a researcher from Australia. So for this, we did a systematic review of the evidence available. We did a Delphi to understand, sort of what is appropriate for this group. And we had an in-person meeting last May, and some of you who are on the call, I'm sure, are with us. I think I saw Daniel Santamino is with us. I saw his name popping up. And we're working on the results from this work right now. So you should see that early 2020. Might be a bit optimistic because it's sort of like early 2020 now, but it's coming very soon. So just to wind up here in the last few minutes, I just want to give an example of sort of what we've done in BC to try and move this needle forward through using our provincial type approach. So in BC, cancer care is organized in a provincial mandate. So we have BC Cancer centers across the province. There are 6 of them. And so we've tried to use that as our main way to kind of push out information about exercise and the exercise guidelines. So the first thing we did recently is we introduced the BC Cancer website to make sure it had an exercise support page. It didn't up until about 1.5 years ago, so now it does. And so what it has is some just basic general information. This was seen as sort of the most trusted source for information in BC around cancer and what supportive care. So that's why we made sure that this was the place it was housed. So there's a little information about recommendations, common questions, and more resources. And this is kind of the common questions, like frequently asked questions type of thing. All this information was drafted. Sarah Weller took the lead on this and was vetted through then a advisory board that included medical oncologists, exercise professionals, as well as patient partners. We also have additional handouts, which are on the next page here. So we have a handout, exercise during and after cancer treatment. So it tries to talk about what the guidelines are, and they need to be updated slightly. Exercise for breast cancer specifically, and then one for maximizing energy and reducing fatigue. And we're doing exercise videos to accommodate all these through funding from the Anita Cochran Award at BC Cancer Foundation. That is in the works, so more to come on that. We also established a referral process. So one thing in British Columbia, we have something called HealthLink, which is the 811, call them directly. I wouldn't recommend you call them right now, but the idea being you can talk to a nurse practitioner, a dietitian, and we also have exercise professionals. So clinical exercise physiologists are also part of this service, and it's called the physical activity services. And so what we knew that this existed within HealthLink, and so we upskilled one of the exercise professionals with ACSM cancer exercise training so that they were more able to handle those calls. Then we did a campaign where we had these little postcards that were around the BC Cancer Agency, and we also had a referral form developed so that oncologists could refer people directly to the HealthLink line. So it can be patient-generated; people can just call up whenever they want to, or the physician can refer them. And this is funded by the Michael Smith Foundation and a great team of researchers here. And I just wanted to update this so at least was current for March, whatever the date is, to March 20th, 2020. Some online resources potentially are what we might be needing in the next several weeks or more. So I just wanted to highlight some things here. This is not an endorsement of any of these videos. You need to consider if these resources are appropriate for the person you're working with, and obviously you need to consider safety. We do a lot of in-person supervision. Your supervision is not going to be in person if you're using these type of formats, but just for example, a potential format we're looking at to do some distance-based counseling. This is Sarah Weller spent a lot of time this week trying to figure out what was easy to use distance-based tool that was compliant with all of our research and healthcare settings. So Doxy.me was suggested by Canadian Physiotherapy Association, of which I'm a member. You can get a free 30-day trial, so you can start with that. There's no downloads or ClickUps or anything like that. It's a really easy format, and so you may want to look into that. Anna Campbell, who many of you know as at Cancer Rehab on Twitter, she is someone that's developed a lot of exercise programming and credentialing in the UK for Macmillan Cancer Support. She has some YouTube videos of cancer exercise programming that you could do online. And Nicole Koulos-Reed circulated just to a few of us this week that they have a suite of online exercise programming that they've been using, but they will make sure it's up on their Thrive website in the next week. So some more Canadian-specific potential exercise tools and videos and things like that that people might be able to use to encourage anyone they're working with that has a cancer diagnosis to stay active at home currently. So I'll just finish with that. All these papers from the ACSM guidelines are open access. The links are here, not very useful. If you were posting these slides, you might be able to use them. Two are in the Medicine, Science, and Sports and Exercise, the journal from ACSM. The last one is, again, from CA, Journal for Cancer Clinicians. Also, too, if you want to hear this in detail again, you can listen to a podcast we did for Oncology Rehabilitation, which is a journal of the American Physical Therapy Association. We have an executive summary that we published that summarizes the information from these three papers, and then there's a podcast with Carrie Winterstone and I discussing it in more detail. So I'll leave it with that, and I'll turn it back to Armine if there's any questions.